Continuing on with our GI pathology, we're going to focus now on the colon. So, colon pathology, we have appendicitis, diverticulosis, diverticulitis, ulcerative colitis, Crohn's disease, ischemic colitis, irritable bowel syndrome, cancer of the colon, large bowel obstruction, volvulus of the colon, and hemorrhoids. So, appendicitis. So, it's the inflammation of the appendix. The causes are obstruction of the flow of a fecalith or from scarring. So, something gets caught in there, so a little stone can form where it gets stuck in the appendix, and it can get gangrene, it can abscess, and it can perforate. So it's more common in children than in adults, but it is possible in adults. We do see it, especially pregnant women. So this is appendicitis that we see on BE, Barium enema. You can see here the filling defects right here in the appendix. So we've got something going on in there. So it's incomplete filling of the appendix. Here is an appendicolith. So if you see a stone on a KUB in the area that the appendix should be, it's probably an appendicolith. And anytime there's an appendicolith, it's positive for appendicitis. It's a given. So diverticulosis. So any kind of diverticulum is an outpouching. So it's a hernia through the mucosa or the submucosa of the muscle layers. So it's a weakness in the bowel wall. So there's a weakness in the bowel wall, and there's an outpouching of the mucosa submucosal through that layer of muscle. So the incidence of diverticulosis increases with age. It's more commonly in the sigmoid portion of the bowel. So the imaging appearance is round or oval outpouching, and you'll see the barium on a barium enema where it's projecting outside the lumen of the colon. And it's usually multiple. It's rare that it's just one, and it usually is in clusters. So here is diverticulosis on a barium enema. So here's your haustra. Haustra is those lines, the indentation in the large bowel. And we have your multiple diverticulum, which is diverticulosis is the disease. So you can see all the little multiple diverticulum on this large colon. So here and here and here, all over. Diverticulitis is when one of those little outpouches gets inflamed. So it's a complication of the diverticulosis. It is defined as necrosing inflammation in the diverticula. So the complications are perforation, abscess, and fistulas to adjacent organs, which is never a good thing. So this is what it looks like here. So you can see the narrowing, and you can see the inflammation within the lumen. So here we have an outpouching, a big one. It looks like it's perforated, so that's not good. Or an abscess, one of the two. So you can see here the inflamed bowel, and that is from a diverticulitis. Ulcerative colitis. So it's an idiopathic inflammatory disease of the bowel. It may be autoimmune or psychogenic due to stress can really affect it and cause flare-ups. So a characteristic feature is alternating periods of remission and relapse. So they'll be fine, then they have a relapse, and then they're fine, then have a relapse. A lot of people get their bowel resected because of this. It usually involves the mucosal layer, so an increased risk of malignancy is associated with this. So imaging appearance on plain radiographs, if you don't see a perforated bowel, do a plain radiograph first, and if you don't see perforated bowel, which means there's large nodule protrusions of the hyperplastic mucosa, deep ulcers outlined by interluminal gas, and loss of haustra markings. So when you look at the descending colon and there's no haustra markings, you need to be aware that we might be dealing with ulcerative colitis. It can involve the whole colon, but is usually It's usually not in the small bowel, and there's no skip lesions like Crohn's. So Crohn's can involve the whole large colon also, but Crohn's will have skip lesions, where we talked about how there's abnormal bowel with normal bowel, then abnormal bowel with normal bowel. So we call those the skip lesions. So usually ulcerative colitis attacks the descending colon, but it can involve the whole colon, but not the small bowel, where Crohn's will involve the small bowel, the ileum, and the large colon. So we do a double contrast barium enema. What we'll see is fine granularity of the mucosal corresponding to hyperanemia and edema. So superficial ulcers look like small flakes of adherent barium produced a stippled mucosal pattern. So you'll see this weird mucosal pattern. It looks like a bunch of little flakes of pepper or something on there. So ulcerations become deep and broad-based. Ulcers like a button on a collared shirt. So there'll be no haustral pattern. The bowel is smooth, and it looks like a lead pipe. So if you see that on a plain radiograph, you need to make sure that you're not going to perforate the bowel. The bowel is very irritated and very tender, and so what will happen is we do an air contrast barium enema, and we were putting air in, we can perforate the bowel. So we need to look and make sure there's haustral markings and there's nothing that looks abnormal before we do any kind of double contrast barium enema. So looking here, the lead pipe, what we talked about, see how there's no haustral markings, so there's no indentations. So this is our concern here. So this is the lead pipe that we talked about. So this is ulcerative colitis. This is a pretty bad case there. Now remember how I said it looked like flakes of pepper? So here you've got deep ulcerations going into the submucosal layer. So it's got that hazy looking appearance in the mucosal layer. So that is our lead pipe also, because there's no haustral markings there. So Crohn's colitis. So Crohn's colitis is second major cause of inflammatory bowel disease. It is identical to Crohn's disease in the small bowel. It must be differentiated from ulcerative colitis. It most commonly affects the proximal colon. Most also have disease of the terminal ileum, and it rarely affects the rectum. So here's the Crohn's colitis. So you can see here we've got little fistulas along the bowel, and this looks different than this and this. So it does have a different appearance, but you also have this lead pipe appearance without haustral, but you also see here the little fistulas. That's not good. So ischemic colitis. Characterized by an abrupt onset of lower abdominal pain and rectal bleeding. Diarrhea is common. It's accompanied by abdominal tenderness. It's most likely people over the age of 50 and have a history of cardiovascular disease, which I found very interesting. So the imaging appearance is superficial ulcerations caused by inflammatory edema and mucosa of the mucosa. As it progresses, deep penetrating ulcers, pseudopolyps, and thumbprinting can be seen. So we'll talk about thumbprinting. Sharply defined finger-like indentations along the margins of the colon. So that is what we call thumbprinting. Usually clears in about a month, and some people can have scarring or adhesions. So here is the ischemic colitis. There's the soft tissue polyp density where the arrow is right here, protruding into the lumen. And I don't see the thumbprinting, maybe right there, there's a thumbprint. So it just looks like someone took their thumb and smudged it and pushed it in. So it's kind of big round prints. All right, irritable bowel syndrome. So it refers to several conditions that have an alteration in the intestinal mobility as an underlying pathopsychologic abnormality. Most common symptoms are alternating periods of constipation and diarrhea. So they switch back and forth. There's no good images of that. So cancer of the colon is the third leading cause of cancer death in the United States. Peak age, 50 to 70. Twice as common in men. So predisposing factors: long-term ulcerative colitis, which I talked about just a minute ago, and familial papitosis, so polyposis, sorry. It's a hereditary disease in which innumerable polyps develop in the colon and elsewhere in the intestinal tract. So these people have tons of polyps, and so they're higher incidence of getting colon cancer. So the imaging appearance can arise from pre-existing polyps. So malignant polyps tend not to have stalks, okay? So a polyp normally looks like a piece of broccoli. So it has a stalk and then the bloom on the top. With colon cancer, the malignant polyps do not have the stalk on it. They have a regular and lobulated surface. They can be large in size, up to 2 cms. Retraction or indentation or puckering of the colon wall. It kind of eats away and pulls the colon in as it's eating away the colon. So annular carcinoma, also known as apple core or napkin ring carcinoma, is the most typical form of primary colonic malignancy. So there's flat plaques of tumor, so they're called saddle lesions, that may involve only a portion of the circumference of the colon. Ulceration is normal also with this. So when we're looking here, this right here is a big tumor right here. It looks like someone took a big bite out of this colon. So that there is a colon cancer. So unfortunately, this here is what we call the apple core or napkin ring. So if you look at an apple core and you can see how it's been eaten, looks like a bite has been taken out of, whereas this one, I don't see the bite out of the other side. This one has it here and on this side. So we've got on both sides. So here's the bottom, here's the bottom. So you can see this apple core lesion or napkin ring lesion. So this is an annular carcinoma. It's an apple core lesion. So on the exam, if I say what is a really bad cancer of the colon, you're going to say apple core or annular. All the students tease me about that. So here is a colon cancer on CT. You can see here we've got uptake of contrast here. We've got thickened wall all around here. So all of this is a really bad, looks like a rectal cancer. So large bowel obstruction. 70% of large bowel obstructions result from primary colon carcinoma. So diverticulitis and volvulus account for most other cancers. Other cases, I'm sorry, not cancers, cases. It is usually less acute than small bowel obstructions. Symptoms develop more slowly. Fewer fluids and electrolyte disturbances are produced. So what does it look like? Depending on the competency of the ileocecal valve. So if the valve is competent, means the ileocecal valve is working, which means that nothing is going from the large colon into the small colon. So the large colon will be dilated and greatly distended, and thin-walled cecum with little small bowel gas. Okay, so if it's incompetent, there is distension of gas-filled loops of both the colon and the small bowel. So here we're talking about the thin-walled cecum with little small bowel gas, and here we're talking about distension. It's usually not as great, but it's gas-filled loops of both the colon and the small bowel, which may simulate adynamic ileus, which we talked about, which the abdomen is just not moving things through. So you need to look to see, is the ileocecal valve competent or not. So perforation is very likely if the cecum distension is more than 10 cm. So you need to make sure it's not more than 10 cm. So large bowel obstruction here, and it's a huge dilatation of the cecum, and this is 13 centimeters, and they haven't perforated yet, but they're high risk for perforation. So this is the large bowel obstruction in a kid. So you can see here we've got dilated loops all over, and this is a 4-year-old, gas pattern indicating large bowel obstruction. A low pressure barium enema was performed to relieve the obstruction, as seen in the post-evac view. So you can see the dilated loops, and we have some dilated small bowel loops in addition, which tells me that the ileocecal valve was not competent. And then we did a barium enema and we cleared it. So with the barium enema, we're able to clear the large bowel obstruction because you can see that there's barium now in the ascending colon, which is great. Okay, a volvulus of the colon. So a volvulus is when bowel twists upon itself. It can cause obstruction, of course. The complications that arise from that, what we've talked about before, are the vascularity. So it can strangle the bowel where it's not getting the nutrients that it needs. So most common sites is the cecum. It's usually caused during fetal development, and the sigmoid due to long movable mesentery. So the mesentery is really long in those areas, so it's easy for it to kind of get twisted up upon itself. So with the cecal volvulus, distended cecum tends to be displaced upward and to the left. Looks like a kidney-shaped mass. So tapered edge of the column pointed towards the site of the twisting. So in the sigmoid, a greatly inflated sigmoid loop appears as an inverted U shape, so upside down U shadow that rises out of the pelvis in a vertical or oblique direction. So that's how you tell the difference. The radiologist will be doing that, which is really nice. So here we've got dilated gas-filled cecum appears as a kidney-shaped mass with the twisting and thickening amongst its mesentery, so right here. So that's where we're talking about. And this one, we have barium obstruction of contrast column at the level of the stenosis. So here we've got kind of like a bird beak appearance, and it's coming around. So this is where it's twisting upon itself. And here's the sigmoid volvulus, so tapering at the site, and here's the bird beak piece where it's coming around. Hemorrhoids. So they're varicose veins in the distal rectum. So esophageal varices are varicose veins in the esophagus. So hemorrhoids and varicose veins within the esophagus, so varices, are the same. They are varicose veins of the distal rectum. Symptoms include pain, itching, and bleeding caused by increased venous pressure, such as with constipation, pelvic tumor, or pregnancy. A lot of pregnant women get hemorrhoids. And the imaging appearance, single or multiple rectal filling defects that simulate polyps. So this is a BE, and you can see here multiple filling defects. You can see all these little things here. Those are all varicose veins, so they're just dilated veins. Here is your summary of the findings for the colon. So it talks about each one, and it talks about the location, the image appearance, and the treatment that they would do. And that will sum it up for your colon. This class should coincide with your 210 class so that you can learn about the pathology and the positioning of the colon together. Good luck.